we will call upon our third speaker, and she is going to talk on cystic fibrosis. And I welcome Dr. Sneha Vargi from Vellore. The madam, I think we met long ago, and she is doing a lot of excellent work on this particular issue. Our interest is in pediatric respiratory medicine, as well as particularly in the pediatric sleep studies. She is very much, and she is going to talk on cystic fibrosis, because I came to know that she is having a very good collection of cystic fibrosis, and she is going to tell us how early you can diagnose cystic fibrosis with the available investigations. And I think many people say that diagnosing cystic fibrosis in infancy will make the child to live for a long years. I think I welcome Dr. Sneha Vargi to go and on the topic cystic fibrosis early diagnosis. Welcome, madam.
Thank you. I hope I am audible.
Audible, madam. Audible. Yeah. Please proceed.
Thank you. So I'm going to talk about how to suspect and diagnose cystic fibrosis early, especially in Tamil Nadu. So before I go on to those specific points, we need to review quickly about our understanding on cystic fibrosis. So as you know, it's a progressive genetic disease inherited as an autosomal recessive condition. The main problem in this condition is persistent lung infections and eventually respiratory failure. So it is considered a lethal condition, and that is the commonest genetic lethal condition among the Caucasians. So among them, the frequency or incidence is very high, 1 in 2,500 to 3,500, depending on the country, but much rarer in the other populations. Asian, Indian, etc., maybe 1 in 40,000 or even 100,000, it is estimated. These estimates are very, very, I mean, it's not based on any study done in India. It's based on studies done on Indians or Asians who have migrated abroad. So it's not very accurate numbers. The phenotype of this condition is very variable. More often we see the severe type, which ends in death or severe morbidity, but there can be milder manifestations of phenotype also. So how often is it there in Tamil Nadu? Dr. Balaji has already mentioned that there are a number of cases here. So one of the earliest reports in the literature is from in our own hospital in the 1980s of 3 cases diagnosed by post-mortem. So it has existed here very, very long time. I know immediately after the condition was recognized among the Caucasian population as cystic fibrosis, within about 10-15 years, we also have recognized that in India. So to look at what goes wrong or what happens in this condition, so this is the cystic fibrosis transmembrane regulator protein. This is a channel or a gate protein situated on the epithelial cells on the luminal aspect. So you can see if this is the respiratory epithelium, each of the cells on the luminal aspect, these channels exist. The function of this channel is to allow chloride ions from within the cell to move to the exterior, that is to the lumen of the airway. So the purpose of this is once the chloride moves in there, the sodium also will move in there together. So presence of sodium chloride will draw water in and keep this mucus very thin, liquidy, and easy to move. Because this mucus has to move, taking all the microorganisms or dust particles which come in, the cilia will kind of transport them upwards to the larynx. So the liquidity or the fluidity of this mucus is very important. That is maintained because this channel is functional and that the chloride ions transport is there. That is why this fluidity of the mucus is maintained. And it's very important defense mechanism in our lung. So in a normal airway where the CFTR protein is functioning normally, all the chloride ions can easily move out and you have a nice, fluidy mucus and a very clear airway. There is no clogging there. Whereas when the channels are blocked, you have lot of thick mucus obstructing the airway lumen and clogged airway and
Some audio disturbance is going on. Madam, I think
Looks like she has lost her internet connection, so I think we just wait
yes,
for
yes, yes, that's what. I think madam is telling about how that clogged airway is a real problem in the cystic fibrosis. Probably her connection is little disturbed. Now I call upon madam because she stopped her talk because of the disturbance. I call Madam Sneha Vargi to continue cystic fibrosis.
sorry about that. So picking up from where I stopped. So in the GI tract, abnormal CFTR protein leads to mainly a problem with the pancreas. So in this slide, you can see that the normal pancreas has got a nice patent pancreatic duct, which drains the enzymes into the duodenum, where the mainly the fat digestion and also protein and carbohydrate digestion happens with the help of these enzymes, lipase and other enzymes. But in when the CFTR protein is affected in this duct cells, there is a problem in chloride bicarbonate transport, and eventually the duct is blocked, inflamed, and destroyed. Finally, eventually this pancreas is almost fully destroyed. It will become cystic and fibrosed, and there's hardly a duct there. So this may take some time. Initially, they may have some amount of pancreatic function, and then over a period of time, they may become totally pancreatic insufficient. So that's the reason for steatorrhea and malnutrition mainly. And also in the GI tract, we are familiar with other manifestations like meconium, ileus, hepatobiliary involvement, etc. Rectal prolapse is another important feature to remember. The other system, salt loss through the sweat ducts is another important problem. And in adults, the obstructive azoospermia will result in infertility in the male members. Now, in the sweat gland, what happens is, so if you imagine this as a normal sweat duct, and this is the ductal lumen, and this is the inside, the interstitium, the CFTR channels are there. So what happens when the sweat is secreted, when it is formed initially in the depths of the sweat gland, it's very high in sodium and chloride, just like our plasma. As it traverses through this tube to come to the surface, the chloride gets reabsorbed back, and along with it, the sodium will get reabsorbed. So if you have a non-functioning channel, the sweat is going to contain a lot of sodium and chloride, and that becomes the basis for the diagnostic sweat chloride testing. So this facility is, like Dr. Sharath said, it's not widely available in Tamil Nadu, but the principle is, induce sweating using pilocarpine iontophoresis. Then sweat is collected either in different methods of collection is there, and then chloride and that is analyzed. So that's the basic principle of that. So when you have a level more than 60 millimoles per liter, CF is diagnosed. Borderline level is 30 to 59, and less than 30, it is unlikely that the patient has cystic fibrosis. So one of the ways of collecting is using a macro duct. You can see this baby is very small, and it can be applied on very young children, even up to 3-4 weeks. But sometimes technically we find it difficult to do it less than 4 or 4.5 kilo babies. So, but technically it can be done. So it is collected in this macroduct tube, and then it is put into this chloride analyzer where the chloride result will come up. You can read out the chloride result in that. So the cost benefit of sweat chloride. So like I said, it is not very widely available. So why not? So the question is, how often is it needed? If you consider cystic fibrosis as a very uncommon disease, we are not going to see it at all, then obviously no one is going to invest on a sweat chloride machine. But that is not the case. We are finding more and more cases of cystic fibrosis recognized, and children with recurrent respiratory tract infection and many other combinations of clinical manifestations ideally should get the sweat chloride test done to rule out this problem along with the other, the etiological workup, sweat chloride also should be done. So I would say all the district hospitals or one hospital in the district should have a sweat chloride testing uh, ability. Now, how valid is the test? You may have some amount of false positives and occasionally false negative, but these are rare. And if at all, if that happens, that just needs to be repeated if the clinical suspicion is high. Now, one thing about sweat chloride is this is diagnosing cystic fibrosis is a life-changing disease. So it is better to invest on that equipment, though the cost of the equipment may be, the one which I showed you, it may be costly like 9 to 10 lakhs. But if you think of, COVID PCR testing, you do a test for 2,000 rupees. That is just valid for that day. The next day or the next day, whether you have COVID or not, this negative result doesn't give you any assurance. Whereas sweat chloride, if it is positive, that is a life-changing diagnosis. You have a definite and clear diagnosis. So, compared to, it is similar to CT scan or MRI or, other equipments which are costly. But if when we realize there are a number of cases around our place, especially, and I can vouch for that in Tamil Nadu, there are a number of cases. So there should be more sweat testing equipment available in the state at least. So other screening tests which can be used are sweat conductivity. Here again, sweat is collected by pilocarpine iontophoresis, and the conductivity test is not exactly measuring chloride. Conductivity will also take into account other ions. So it is considered a screening test, but a level more than 80 closely corresponds to a level more than 60 of sweat chloride. So that also can be used because the cost is slightly less with the sweat conductivity testing. Aquagenic wrinkling, Sharad Balaji referred to it. This is Dr. Cabra's study, which was published in 2019. So here you can see a value of 3 minutes they have taken as. When you take a value of 3 minutes that the patient's Parma skin wrinkles within 3 minutes of immersion in water, that test has a sensitivity of 80% and a specificity of 56%. So the specificity is not very high. So if it just because it wrinkled, you can't say it is cystic fibrosis. So it's just a screening test. With the appropriate clinical testing, it may be useful to give you one more clue. That's it. This study is done in US. It is just published now. So this is done by Dr. Grace Paul. She is also the collaborator with me for the Cystic Fibrosis Project India. Here, what they have done is they have done this on infants, very young infants, to see can we screen infants and decide if they have, whether they should go for a diagnostic test or not. So you see, cystic fibrosis patients have very low, at an early time, 3 minutes they wrinkle with a confidence interval just spanning 2 to 4, up to 4 minutes. Whereas controls and the carriers are also, they are proven to have one mutation. These patients are all genetically proven cystic fibrosis. The carriers have one mutation. The controls are healthy. They don't have any mutation. So you can see they are far apart from this. So this is, it could work as a good test, but remember, it does not have a very high specificity. So we can't diagnose anybody based on this. Genetics is the other test which we usually do for diagnosis. Now, if you look at how the CFTR protein is formed, the information is inside the cell, the DNA. So as we know, we receive it from the mother and the father, one gene. And in an autosomal recessive condition, we need 2 mutated genes to manifest the disease. If you have only 1 mutated gene and one normal one, you're going to be a carrier, and the patient will not have any manifestations or the disease. So the instructions from the DNA are transferred to mRNA, and the protein is formed. It has to mature into a mature protein and reach the surface of the cell and function as a chloride channel. This is what normally happens. But there are, known to be about 2,000 mutations. These mutations can interfere, can result in a problem which may affect any of these steps. So based on that, it is classified into different classes. So class 1 mutations, there is no proper instruction to make RNA or the protein at all. So all the mutations belonging to class 1 will not result in the formation of any amount of CFTR protein. Class 2 mutations, some amount of protein may be formed, but it doesn't mature because it is improperly folded and hence it will not reach the surface. So this also finally will not result in any type of proper CFTR channel, and the patient will have all the manifestations. So these two classes of mutation will lead to a severe phenotype of CF. Class 3 is the protein somehow reaches the, it's okay till now. It reaches here, but it doesn't open properly. Then there are class 4, 5 mutations. All these mutations, what they do is either the number of channels is less or they are unstable, etc. So eventually they don't work well. The channels don't work well. So they may have a lesser phenotype. Now the treatment, I'm not going into details, just to summarize. The one of the problem is in the lung, the clogged airways. So you use hypertonic saline as a thinner to move this, thin this out. Use airway clearance maneuvers, chest physiotherapy, breathing techniques, etc., to clear this. And when you need a lot of antibiotics because Pseudomonas, Staphylococcus, etc., colonize there. The next problem is with the pancreas. So nutrition, pancreatic enzymes along with food, fat soluble vitamin supplementation, and also remember salt loss is excess. So in the nutrition, you must add salt also. The basic defect, as we know, is in the CFTR channel. Now there are new medications for this. These are molecules, small molecules, which are called as correctors and potentiators. So either the folding, they help, or they help an improper channel to open up. So combination of correctors and potentiators, one specifically called Trikafta, which is a combination of 3 drugs, is almost could be called a magical drug, which has really changed the way cystic fibrosis patients look at their life, because they were looking at a bleak future, going to die in the near future kind of thing. Now they are looking forward to having a career, living longer, having children, grandchildren, and anything, a long life. So that is a life-changing, drugs are coming into use now. So now my topic specifically was early identification of CF. So the question is, why should we identify early? I mean, what's the point that we should identify early? So what is the strategy that should be used? What has worked world over? Is that the same thing we should be using in India? So now in India, if you look at all the statistics, on an average, the children may be diagnosed between 4 to 6 years of age, sometimes as late as 20 or 25 years. But on an average, many studies, it's about 4 to 5 years. By this time, patients would have developed bronchiectasis. And from then, it's a downhill course, because bronchiectasis by itself causes more infection and more destruction of the lung. So you have lost the opportunity to give them a good quality of life, and the life expectancy proportionately will be shorter. So, and even if these new drugs, which are working miracles abroad right now, which comes to us, if the child has got a very established bad bronchiectasis and a very poor nutrition, then the effects of these drugs are also going to be suboptimal. So definitely we need early identification to get the best quality of life and prolong their life appropriately. So the best strategy is newborn screening. So the principle here is the pancreatic problem, the pancreatic injury starts in utero itself. So when the baby is born, a heel prick and that blood sample taken on a filter paper or a paper and tested, you can store it and test it in a few days' time. You look for elevated immunoreactive trypsin. So that's a pancreatic enzyme. So the pancreas is injured. This enzyme will leak into the bloodstream and you will have a higher level. So this will help to identify the babies by 2 to 3 weeks in most countries. And this is only a screening test. After that, the confirmation has to be done using sweat chloride testing. And that will help in early initiation of treatment before, by 3 to 4 weeks of age, before severe malnutrition has set in. And patients can have better BMI, better lung functions, and longevity of life. Multiple studies have proven this. I'm not going into the details of those studies, but almost every single study has definitely proven this. So the protocols may be to use 2 tiers of IRT, or some countries where the mutation, most of the population, 85% of the population may have the same mutation. In that case, they can look for that mutation along with the IRT, and then you can have the genetic diagnosis also at the same time. So different protocols are used in Western countries. The question now is India ready? Is the logistics of doing this newborn screening on a national level? You have to follow up the positives, follow up the negative, I mean, not follow up the negatives, follow up the positives, call them back for sweat testing, counsel them, advise them, provide the correct treatment. So are we ready for it? It may be debatable right now with a lot of other priorities that may not be immediately work. And what strategy will be used? Are we going to use IRT, or if you have to use DNA, it may not be very suitable because our genotype is very kind of colorful, I must say. There are lots of mutations which are present here. The most common mutation in the Caucasian, which is del phenotate, is only about 20 to 25 or 30% at the most. The rest 70 to 80% are different types of mutations in India. So we can't choose one or two or three mutations to screen. So that's going to be a problem. Then what? What can we do then? Are there any other strategies? So one thing we can do is to be proactive. So one thing we have noticed is growth failure is an early feature. This has been noticed in Western countries. By the time they finish the screening for the screening with the newborn screening and call them back for the sweat chloride, they notice by 2 to 3 weeks itself, the patients are failing to thrive. So what about here in India? This is a few babies who had their diagnosis in infancy. We just looked at to see how they are, how their growth is. So this is the weight for age Z score. That is this picture, weight for age Z score on this y-axis. So you can see you would expect normal to be somewhere close to 0. So even up to -1, -2 is okay. But at the time of diagnosis, at an average time of 3 to 4 months, it was -4.68. And with treatment, it improves. But it takes more than a year for them to get back to something reasonable. So that is very severe malnutrition, very difficult to get them up to normalcy. Now, we asked one question at that point of time. What was the birth weight? Birth weight was all very good. It was normal. It was very much acceptable, close to 0 Z score. But to the question, what was the weight at the time when you went for vaccination? We asked all of them that question. The first vaccination when they went around 6 to 8 weeks of age, by then their weight had fallen actually very, very much. So someone could have picked it up before this diagnosis, which happened 3, 4, 6, 8 months later. Someone could have picked it up right then when that growth failure started. So there was a missed opportunity. So with this, we started a surveillance of failure to thrive infants. So we just started this on February 16th, my team of nurses and one of the PG students. So it's only about 3.5 months. So just keeping a close watch on the weighing machine. Wherever babies are weighed, somebody was watching what is the weight being recorded. This is only babies who are born with a normal weight, not low birth weight, no preterm, no very low birth weight babies. If they had birth weight more than 2.5 kg and they were failing to thrive, that is less than third centile, we identified 96 infants. Remember, this is half the time is lockdown, so the patients coming to the hospital is very less. So this is probably half what you would expect in normal times. And we did them clinical screening, history, and all those etiological screening. Also, we did an aquagenic test, aquagenic wrinkling test. So 12 of them out of this was screen positive. But they were not all of them were CF. We identified 3 infants out of this. So in this short span of time, we were able to identify 3 infants. So these 3 infants had other features also. They were not only failing to thrive. By the time they came, our intention was to find when the first problems happens, that is failure to thrive happens, but these babies we picked up a little later. The other problem is, Sharad referred to this about summer dehydration. This case, I keep showing it because looking through this chart is what really changed my outlook about cystic fibrosis. This is a baby. I mean, he's a teenager now. He came in 2008 with the acute gastroenteritis. That was the first visit. We treated him, sent him. He came with bronchiolitis. We treated him, sent him. The next year, he came with dehydration. 2 years later, he came with dehydration. Next, he came with severe dehydration. Year after year, he came back with dehydration. Every time he was appropriately treated. But what got missed is the reason that this child is coming in the summer every time. And finally, the diagnosis was made only by the time when he was 4.5 years, because at the time when he was admitted into ICU with the dehydration, he had all the typical metabolic derangement. So watch for electrolyte imbalance with dehydration. This is summer, May, June, July, Tamil Nadu, the worst of summer. In a way, summer is a blessing in disguise, I would say, because these babies are brought to us. Brought to us because even with lockdown, they can't stay at home because they will become lethargic. They start vomiting because they develop hyponatremia, and the parents will bring to them. And the thing is, it's very easily correctable. 1 pint of IV fluids and this will correct. And if you send them off, you lost the chance. You lost the chance to pick up that diagnosis. So if you find hyponatremia in the summer when a baby who is presenting with lethargy or you know just a vomiting, so the vomiting is not the reason for hyponatremia. The vomiting happens when the hyponatremia reaches a critical level. This has been observed in the World War also. When the soldiers were exposed to extreme heat and then they develop hyponatremia, at a particular point, they will start vomiting. Okay. So when these babies come with this presentation, that's our chance to pick them. So again, we observe that around Vellore, Tiruvannamalai, Chittoor, etc., this type of phenotype is very common. It may be common in other places also. So this is a typical ABG. This is this patient. You can see the date, 30th of April. You can check the temperature of Vellore that day. It was high temperature that day. And this is the baby came to one of our peripheral hospital. Even the peripheral hospital, we had alerted this kind of a situation will happen, and they were able to pick up and send to us. And you see the results, sodium is 122, potassium is 2.7, chloride is 78, bicarb is 33, and pH is 7.57. This is the typical feature you will see. Even if you don't have ABG, don't worry. Just the hyponatremia, this scenario, if you see, just, monitor that patient. The other way to recognize these patients is to maintain a syndromic approach, a pattern recognition of sick babies with specific pattern of results. So patients who are getting into ICU with history of severe pneumonia, if they have very severe airway obstruction picture, sometimes recurrently they keep coming, or the bronchiolitis doesn't seem to resolve. Hyperinflated X-ray, bronchiolitis is a very common condition. So every patient who comes with bronchiolitis does not have cystic fibrosis. But when it keeps happening again, think of it. Give it a thought whether are we missing a cystic fibrosis case, especially if there is failure to thrive or any sibling death or any kind of other features are present. Pseudomonas you find in the airways when you do a BAL or a intubated patient tracheal culture. This is not a common bug in a normal child. Only an immunodeficient or a cystic fibrosis patient will have Pseudomonas in the airways. So immunodeficiency you can rule out very easily. If not, then it is probably cystic fibrosis. Also, patients who have been in ICU for a long time may pick up Pseudomonas. That's another matter. And metabolic alkalosis when you expect acidosis. Your sick child, dehydrated, shock. You are expecting metabolic acidosis, but here you find metabolic alkalosis. So this kind of a syndromic or a pattern recognition, if you use, you may be able to pick up early. This is a triad of, we call severe acute malnutrition. Really, that, kwashiorkor is really about an age of about 1 year, 1.5 year age. In an infant who presents with severe acute malnutrition, skin changes, with anemia, this kind of I hope you can see that the hemoglobin is very low here, and albumin is also very low. In the same frame, you have hypoalbuminemia and anemia and hypoalbuminemia in an infant. So less than 6 months, there are very few reasons why you will develop anemia. You think of bone marrow failure or blood loss or something like that. But less than 6 months, you don't get anemia very, very commonly. So when you have that kind of anemia requiring transfusion along with hypoalbuminemia in a baby who is failing to thrive, don't forget to think of cystic fibrosis. So this is not a new information. This was recognized long time back. I mentioned, the article from our hospital. There also those babies had the same problem. So differential diagnosis, many common differential diagnoses are easily possible. Any of them is possible. I am not saying it's all going to be cystic fibrosis, but keep cystic fibrosis also in mind. Suppose when they have diarrhea, sometimes we may think of cow's milk protein allergy because that will also have the similar kind of features. So consider this also and side by side evaluate. And one thing the confirmation of diagnosis is going to take time. Sweat test cannot most likely can't be done when the child is edematous and very sick like that, and genetic test is going to take 2 months for you to get the result. So at this point, what you can do is to start treatment empirically. You know it is empirically, so that's okay. You can start empirically, give pancreatic enzyme supplementation, supplement ADEK because E is the reason for vitamin E deficiency is probably the reason for the anemia or some hemolytic component, and A also may interfere with the airway epithelial integrity. So these are all life-saving in that situation. K may cause severe bleeding at some point or the other, sometimes intracranial bleed. So these are life-saving supplementation you may be able to give at that point of time. So this kind of phenotype we see more commonly in the central and southern districts of Tamil Nadu. Del-phenotate homozygous also present very frequently like this. Meconium ileus is well known, it is cystic fibrosis, but you will be surprised that many surgeons, they treat Meconium ileus, but they don't, they might think of cystic fibrosis, but they may not make the appropriate referral. So make sure your pediatric surgeons, your group of pediatric surgeons who you refer to is very much aware of Meconium ileus as a presentation of cystic fibrosis and refer the patient to you, especially if the patient has had ileostomy, the fluid losses from the ileostomy, the malnutrition, it is going to be very, very difficult to manage these babies. A lot of them die. So treat these patients very aggressively right from the beginning. And of course, always search for positive family history, infant death in these families with any of this presentation or any suggestive history is there. You must suspect that a child, in that case, you can do at the time of birth, you can do an IRT because it's available in our country. It's not like it's not available, but as a national program, it may not be available. So you can order that IRT test and diagnose in the at time of birth itself. So to summarize, on the ground, what can we do? So the main thing is suspect, always suspect. Keep cystic fibrosis as a possibility in many of these conditions. Don't think of it as a Caucasian disease or something which does not exist in Tamil Nadu. It does exist in Tamil Nadu. My rough estimate will be it will be like 1 in 10,000 babies born, at least in the Vellore district, I think have cystic fibrosis. It's a very rough estimate. I can't prove it right now, but one day we will prove it. And screen them using clinical clues, and sometimes aquagenic wrinkling may be a good screening test to do. It doesn't diagnose, but it will give you another clue. And start empiric treatment because this treatment is not going to damage. It's not like chemotherapy or something, it will damage the baby. Giving a little pancreatic enzyme creon is not going to do any harm because it's a minuscule dose compared to what our body is producing, but it can be very, very life-saving. So use start it, counsel the parents that the treatment is not finalized. It will take time, they have to be patient, but we don't want to waste time. That is why we are treating this. And also counsel them about recurrence risk because it's an autosomal recessive condition. There is a 25% chance, 25 in the next pregnancy. 25% chance may sound like a less chance, but it is for each pregnancy 25% chance. And in many families I have seen, pregnancy 1, 2, 3, 4 has been in a line, have been affected babies. Antenatal diagnosis is available, so they can make use of that. And use the available opportunity to diagnose. So DNA sample for diagnosis in the in the algorithm, sweat chloride is the test for gold standard test for diagnosis. If you go straight for if you just have a clinical suspicion and you go for genetic test, you may get a result which you don't know how to interpret because many of these mutations are not mentioned or they will come as uncertain significance, and after spending 17 or 20,000 rupees you won't have a result to give the family. So first diagnostic test to do is sweat chloride, followed by genetic testing if you want to use that information for antenatal diagnosis. But if it's a sick baby, or if it is the first baby of the family, and especially the baby is likely to die, it's in a very sick condition, please save a sample of DNA. They may not be able to do the test right then, they may not have the money or the facility to do it, but that saved sample can be used later, and that parents can avail of antenatal diagnosis at some time if they wish to. So save that sample. So where can you find help? Clinical decision making, meaning you need to consider all the differential diagnosis, keep going using all the algorithms for different differential diagnosis you have considered. You can keep proceeding, but keep this on. I am happy to be contacted anytime to talk through this cases, to see which test to order, how to go about it, etc. Sweat testing in Chennai, there are a couple of places I am told, KKTCH and Surya Hospital, etc. In our hospital, we do it. The cost of sweat testing may range from anywhere from 2,500 to 3,000 or a little more than that. But I am able to do it at a much cheaper rate because we have a project going on here. I'm happy to help if you have a case with significant doubt. Fecal elastase is another test. This fecal elastase is an enzyme produced by the pancreas. It will come in the feces. So if elastase is very low, that means the pancreas is not functioning. And in children, the commonest reason why the pancreas is non-functional is cystic fibrosis. So it gives a very good clue if you have a low fecal elastase. So some gastroenterology centers you may find they will do fecal elastase. Genetic test I already mentioned. So you have to be careful when you're using a panel. If you don't get a positive panel, it doesn't mean that the patient does not have the test. You might have to do the full sequencing to make that. So we are happy to help with diagnosis anytime. This is our email and contact number. The aim of the project we are doing is to raise awareness and help doctors make diagnosis of CF. So we would be, after this COVID pandemic is over, we will be, we have traveled before with the sweat machine to make diagnosis, help doctors make diagnosis. We'll resume that. We may be, if you want to set up the facility in your hospital, we may be able to give training also. So that's from our side. Thank you for the opportunity, and again, sorry for the interruption.
Thank you, madam. Thank you, Vargi. I think madam has covered